live now.
Good afternoon to all the delegates and the eminent speakers. Thank you all for joining this afternoon. I am Siddhant Sharma on behalf of Hetero Healthcare. Welcome you all for webinar on the introduction to Benbidovic acid, non-statin lipid lowering agent in the management of uncontrolled LDL-C. As you know, doctor, lifestyle disease in our country is on rise and it's surprisingly moving towards chronic stage. We at Hetero Healthcare has always been at forefront along with your side to deal with such ailment. This afternoon, our esteemed and experienced doctor will share their experience on the subject. Before proceeding further, let me take the privilege to introduce our eminent panelist, Dr. Vivek. He is a consultant cardiologist at BGS Hospital, former associate professor at Department of Cardiology, Kasturba Medical College, Manipal. He is a life member of Cardiology Society of India and Pediatric Cardiology Society of India. He has been awarded as the best case report in BMJ Case Reports Journal, which is held in KMC in the June 2013. He has participated in many national as well as international level of conferences. He has covered overall 58 well-renowned publications and 10 research articles. Also glad to introduce our second panelist, Dr. Krishna. A warm welcome to you on the scientific talk. Dr. Krishna is a consultant physician at ProMed Hospital and Tanmay Clinic at Diagnostics. He is also a member of American Thyroid Association and associate member of American Cardiology Association. He has participated in many state and national level of conferences. He has been awarded as the best paper presentation at KPI Con on Diabetes Mellitus. So I welcome Dr. Vivek and invite him to take over the session.
Thank you, Siddhant. Thank you for a nice introduction.
Hi, thank you. Thank you all. Thank you for giving me an opportunity. At the outset, I'll tell you it's a new molecule even for me. So I also had to go through a lot of literature. And it's been a nice changeover from our regular statins. Okay, the slides are visible?
Yes, doctor.
Yeah, okay. So I'll just be giving a brief introduction on how our cholesterol gets absorbed and the usual cycle, the Krebs cycle, how it works, what is the basic premise of using hyaluronic acid, and how statins have been a mainstay of therapy for cholesterol lowering over the last 30 years, and how the new molecule, which I'm going to talk will give us an added benefit over statins in patients who are resistant or patients who are intolerant to statins. So with that brief introduction, I'll just go through my slides. We all know that dyslipidemia is a has a major impact on the cardiovascular and the cerebrovascular morbidity and the peripheral vascular disease. So since I'm a cardiologist, I'll be talking more on atherosclerotic cardiovascular disease, but we all know that the prevalence of cerebrovascular and vascular disease in the other compartments are as frequent as a cardiovascular disease. So even though the urban and the rural population had a significant gap in the past, I think the rural population with this increased incidence of obesity is catching up with all kinds of vascular diseases. So the major adverse cardiovascular and the cerebrovascular events are quite significant in both the urban and the rural population. So we all know that, you know, the n number of guidelines in the last few decades, which say that the cholesterol levels have to be maintained within an acceptable limit with whatever form, whether be it diet, be it lifestyle with exercise, or a combination of a lifestyle, diet, and therapy. So despite all these, a certain subgroup of patients tend to have recurrent vascular events, even though their cholesterols are controlled, or on the other hand, there'll be a n number of patients who, despite lifestyle measures, despite diet, and despite a stiff dose of statins, fibrates, and ezetimibe, the cholesterols are still pretty uncontrolled. These are patients who are clinically challenging to manage. And these are patients who have a high risk of recurrent cardiovascular events. These are patients who come with restenosis, stent thrombosis, and these are the patients who end up getting a bypass surgery. So it's very important that we prevent and treat dyslipidemia well, and it becomes very important in managing our cardiovascular patients. Now, what we have certainly seen over the last few decades is that the incidence of cardiovascular events have dramatically come down from 60 to 30 to 40. And when we check the cholesterols of these patients, they're pretty high. They're all deranged. They all have high LDL, high triglycerides, a very low HDL cholesterol, and it's kind of become a kind of a pandemic now with the increased incidence of work from home in these individuals. So especially in Indians, where the exercise is pretty low, and traditionally we are the diabetic and the coronary capital, there's a very high incidence of cardiovascular events in our population. And we know that more than 2/3 of the deaths are cardiovascular in our population. So basically a small gist. So we basically, in terms of estimating the fasting lipid profile, we look at these parameters: the total cholesterol, the non-HDL cholesterol, the LDL cholesterol, and the HDL cholesterol. So what we are more worried in terms of cardiovascular morbidity or mortality is the LDL cholesterol. We want to keep it less than 100, especially in very high risk individuals. And we need to keep the good cholesterol, the HDL, more than 45. Targets for the non-HDL and total cholesterol are as depicted in the table. So these are the values which we tend to keep in patients who are at high risk of recurrent vascular events. And what are the current challenges and what are the gaps in cholesterol management? So we know that both the ACC and the ESC have recognized that LDL cholesterol is the one which is the main culprit in atherosclerotic plaques and cardiovascular events. So LDL reduction is the main target in all guideline-directed medical management of dyslipidemic patients. So where statins has the main role, and then if statins do not control, we have one more molecule, ezetimibe, which acts with a different mechanism and try to lower the LDL cholesterol. So these two have been the main armamentarium in decreasing the LDL cholesterol levels. We know that the high cholesterol and now the triglyceride level also is significantly correlated with atherosclerotic coronary artery disease. You add on blood pressure, smoking, and insulin resistance, especially in patients with diabetes, you start getting the typical atherosclerotic deposition. And when it reaches a critical stage or when there's a plaque rupture is when you get all our acute coronary syndromes. So these are the group of drugs which are typically used in lowering the cholesterol, the various cholesterol. Statins, we know the commonest molecules used are atorva and rosuva. They tend to remove cholesterol from the blood. Then the cholesterol absorption agents, the ezetimibe, again, they limit the absorption of dietary cholesterol. So what we're talking now is the ACL inhibitors, the bempedoic acid. This has a different mechanism of decreasing cholesterol. It acts higher up in the cholesterol, in the Krebs cycle. I'll be talking about it a little bit later. Then the other old ones which we hardly use are the bile acid binding resins. Niacin, we need to use a very high dose of niacin to decrease the LDL and the triglyceride levels. And the fish oil, the omega-3 fatty acid supplements, again, to decrease the triglycerides. So these PCSK9 inhibitors are a group of drugs which are not very commonly used because of the cost and the rarity of patients. And again, these also help in decreasing the LDL cholesterol by helping the liver absorb more of the cholesterol from blood. So what we're going to talk about is the ACL inhibitors, the bempedoic acid. So again, like I told you, very high baseline LDL levels is seen in almost 80% of the patients. And because when we tend to increase the statin dose beyond 40 mg and when we go to the 80 mg, the compliance comes down because of significant muscular side effects. The patients complain of severe myalgia and they stop taking the tablets. So here's where is one of the gaps of the lacuna of high dose of statins. So what we actually noticed is one, the residual risk, even with a high dose of statins, the cholesterol doesn't come down. The patient's target is not achieved. The cholesterols don't come down. And like I told you, non-adherence. So these are the three main risks of very high dose of statin therapy. So basically statin intolerance and muscle weakness or myalgias. So we need something else, an add-on treatment, which would reduce the LDL levels. So I'll give you a brief introduction of what is bempedoic acid. So how does it work? So this is basically initially started off for treatment of refractory hypercholesterolemia, the familial ones. And then its indication extended to patients who are resistant or intolerant to statins, and as a monotherapy as well in the latest trials. So basically, it's an oral tablet, and you give it at 180 mg per day, once a day. So it's rapidly absorbed in the small intestine, and food has no effect on bioavailability. And Tmax is 15 and 24 hours, and 99% is plasma bound. So it basically is converted to an active metabolite reversibly, and its excretion is mainly in the urine and part of it in the feces. So basically, it is a prodrug. It gets activated by the ACSVL1 enzyme to bempedoyl-CoA, which is the active form. Now, this active form, we know citrate is where the Krebs cycle begins, and citrate is converted to by the acetyl-CoA to the further molecules, the mavulanic acid and the cholesterol. So we know that the statins are acting on the rate-limiting step, the HMG-CoA reductase enzyme. So where bempedoic active, the acts is even higher up, 2 steps higher up in the Krebs cycle. It acts on the acetyl-CoA enzyme reductase on the enzyme, and inhibits the formation of cholesterol. So it's like an add-on therapy. Wherever there's a leak in the statin, the bempedoic acid can plug it up way higher. So since it has a different mechanism of action, so it's always an add-on therapy. So this summarizes it even a little bit better. Bempedoic acid is converted to the active form. It inhibits the ACL. Statins is where it inhibits, and there's a decrease in the cholesterol synthesis. There's an increase in the LDL receptor upregulation, and more LDL receptors. LDL is removed from the blood. Now, how is it deactivated? It is converted to a glucuronide conjugate and is excreted mainly in the urine and in the feces. Now, one thing that's different from the statins is that it has no effect on the skeletal muscle. There are no ACL enzymes in the skeletal muscle, so hence it has no action on the skeleton. It doesn't have any skeletal muscle side effects. Whereas statins have a significant skeletal muscle side effect. So this is basically about the pharmacokinetics of bempedoic acid. So this is what I told you. The ACL-VL1 enzyme is mainly expressed in the liver and the kidney, never in the skeletal muscle. So it has none of the side effects of statins. So the medication adherence is more in these patients. Okay. So this is the same thing in another slide. So muscle weakness is rarely noticed, and patient adherence is better with bempedoic acid. So the first approval in the USA as a monotherapy was quite recent, just 2 years ago. It was around February of 2020, and as a combination with ezetimibe, which has a different mechanism of action, decreases absorption. So the combination of bempedoic acid and ezetimibe was again approved in the February of 2020, and it was as an adjunct to diet and maximally tolerated statin therapy, especially in patients with heterozygous familial hypercholesterolemia, or in patients with an established atherosclerotic cardiovascular disease. So it's a new drug, and for an old indication. So that's how I would put it. So where do you use bempedoic acids? Either in the monotherapy or as a combination with statins in patients whose target is not achieved, or patients whom you can't achieve the very high dose of statins. As an add-on therapy to statins, we can use bempedoic. So what have they seen? What have they noticed? There's a significant reduction in the apolipoprotein, HDL, and the LDL levels. And also it decreases the high sensitive CRP levels, just like how statins do. And in patients with diabetes, they've noticed a 43% reduction in the LDL-C and the hsCRP. So it actually lowers the LDL-C almost 20 to 30% in patients who are on bempedoic acid as a monotherapy. So what does it do as a combination? So with statins, what does it do? So with statins, again, it also has an additional effect, and it reduces the LDL levels by another 22%. So it's quite safe and effective when used along with the statin in patients who are intolerant or they can't tolerate a very high dose of statin. So in my clinical practice, so where would I see it? I would say it's definitely an add-on therapy in most of my patients. who are not tolerating a 40 mg dose of rosuvastatin or an 80 mg dose of atorvastatin. So in these patients, you can easily add on a bempedoic acid. So indications. So basically, this is what I told you. It's basically for hypercholesterolemia, either in the familial ones or the established atherosclerotic cardiovascular disease, where it's used as an adjunct to diet and statin therapy. So the dose is 180 mg once a day. So there are some interactions. You don't give it in patients who are on Simva and Prava. Simva and Prava is hardly used in India, so we don't have to worry too much about that. So they're actually safe in patients with rosuvastatin and atorvastatin usage. Obviously, in pregnancy, lactation, and pediatric, there are hardly any trials. You have to be very careful in this special subgroup population. So there are some rare adverse reactions in these patients. One is muscle spasms and tendon ruptures, which are seen in some patients. Then hyperuricemia, and some patients exhibit pain, back pain, abdominal discomfort, but these are quite rare, and some patients tend to have an elevated liver enzymes. So where do you actually be a little careful? One, in patients who have a history of gout or who have an elevated uric acid, you have to be a little careful. And patients who have, history of, tendinitis or tendon rupture, these are some rare adverse effects of bempedoic acid. So that's basically the pharmacokinetics and the pharmacodynamics. So what do the clinical trials tell us? There has been some clinical trials, mainly the CLEAR studies. The CLEAR study, the Wisdom, Add-on, Harmony, Tranquility, all these are basically the bempedoic acid studies. So I'll just brief you a bit on this. So CLEAR is basically cholesterol lowering via bempedoic acid. So in this CLEAR study, basically the first one where the safety, the efficacy and tolerability of bempedoic acid was assessed in 345 patients with a mean age of 60, and it was quite safe and well tolerated. Okay, that was the basic CLEAR study. And then the Harmony study, CLEAR Harmony study, was patients how did it work in patients who are already on guideline recommended statin therapy? How safe was an addition of bempedoic acid? So in a 52-week trial, in patients who are treated with bempedoic acid, in patients who are already on maximally tolerated statin therapy, there was no significant adverse events, and it reduced the LDL cholesterol further. So this was the CLEAR Harmony trial where it was added on to statins. And then the CLEAR Wisdom trial. Here bempedoic acid was assessed with placebo against which was added to a maximally tolerated statin dose in patients at high risk for cardiovascular disease. So in these patients, again, when they assessed it after 3 months, they found that there was a significant reduction in the LDL cholesterol. So it's easy to say that when you add it on to a small dose or a maximally tolerated dose of statin, bempedoic acid is quite safe and effective in lowering the LDL cholesterol further. And then patients who are on the Tranquility trial, CLEAR Tranquility, these are patients who are statin intolerant. So when you add bempedoic acid to patients who are statin intolerant, what happened? So again, in these patients, it was well tolerated, and it would, in combination with ezetimibe, it would actually give us an alternative in patients with statin intolerance. So patients who have, even with a mild dose of statin, who develop severe myalgias, in these patients, you can easily give bempedoic acid alone or in combination with ezetimibe to lower the cholesterols. So this is basically the 4 trials, the Harmony and the Wisdom and the Tranquility and the Serenity. This is basically what it summarizes. These are patients who are already on statins, and these are patients who cannot tolerate statins. So patients who are already on statins, again, in these patients, there was a significant decrease in the cholesterol levels and the safety and the tolerance levels. And here is the patients who are not on statins. So this is again the same thing. The top 2 trials, the Harmony and the Wisdom, are patients who are maximally tolerated statin therapy with the background of statin therapy. And here, the Serenity and Tranquility in patients who have no were not able to tolerate statins, again, the patients did well on bempedoic acid. So some key pointers, how do you actually use them in clinical practice? In renal impairment, there's actually no significant dosage impairment adjustment necessary in hepatic and renal, but kindly note that in severe liver dysfunction or severe kidney injury, there are no studies. In patients with high uric acid, you need to be careful. If they have a past history of uric acid, high uricemia or gout, you need to be careful with them. And then patients who are more than 60 years of age, who are taking corticosteroids or fluoroquinolones or renal failure and a history of tendon rupture, you need to be very careful in these patients. And if it actually occurs, you need to discontinue it. Like I told you, Simva and Prava is hardly used in India, so we don't need to worry about them. But when patients are taking this, when they come from abroad, you should be very careful in starting these drugs. Pregnancy and breastfeeding, obviously, there's no recommendation for using bempedoic acids. So this is bempedoic acid and hypercholesterolemia to conduct a phase 3 clinical trial in 1,200 patients, and just oral bempedoic acid, how did it fare and what was the percentage reduction again in patients who are bempedoic acid was added to patients to maximally tolerated statins or no background of statins. LDL significantly decreased in these patients who are on bempedoic acid. And now there was one main concern with statins is the incidence of diabetes, new onset diabetes in patients who are on high dose of statins. So sorry.
Please go on, doctor.
I think 1 second, the slide closed. So basically the last trial which I was supposed to say was whether there was any significant increase in the insulin level and the glucose levels in patients who are on bempedoic acid. And the trial showed that there was no significant incidence of new onset diabetes or variation of the sugar levels in bempedoic acid. So that's one concern which was not a major concern for patients who are treated. So one of the main reasons why statins have come to take a lot of flack is because of the incidence of new onset of diabetes in these patients. So that's spread like wildfire, that if you take statins, you develop diabetes. So that risk is also not there in bempedoic acid. So with that, I'd like to summarize. Bempedoic is quite safe, whether you give it as a monotherapy or as an add-on therapy with statins or with ezetimibe. And in patients, especially in patients whose cholesterol are not coming down, with good tolerated dose of statins, you can add on bempedoic acid. I wouldn't say stop statins in these patients. It always has to be an add-on because we know the statins has been there for 3 decades with us now. So this is a new molecule, and honestly speaking, I haven't used in many. So with obviously with usage, clinical experience will grow. So with that, I would like to stop, and I think we'll take questions at the end after Krishna's talk, I think. Okay.
Dr. Krishna's view on the bempedoic acid. Dr. Krishna?
As Sir has told, it can be add-on therapy along with statins. The statins we cannot see. Statins has to be given for primary. Statins are used for primary prevention as well as for secondary prevention. So there is what you call. I don't think so. Bempedoic acid can be used for primary prevention, but statins are used for primary prevention. So as Sir has discussed, that can be combined with the statins where there is a refractory dyslipidemia, or it can be used in case of familial dyslipidemia cases. And as you said, it's got a less side effect, and there is a less chance of muscle inflammation, and as well as a decrease in the chances of diabetes. It can be used as an add-on therapy. Almost those are refractory to the regular statin therapy.
We have some questions in the chat box.
One second, I'll go. See, as discussed, as Dr. Vivek discussed, if there is a very high level of LDLs, then it can be given as a primary monotherapy, or it can better to start with an statins, and you can add a bempedoic acid as an add-on therapy instead of a monotherapy, what I suggest. There is no need to stop a statins when you're using a bempedoic acid, because statins have got other good effects, like it improves the endothelial functions, it moderates the inflammatory responses, it causes plaque stability, it prevents blood clot formation. There are many other benefits of statins, so it's better to use bempedoic acid as an add-on therapy with the statins than giving as a only monotherapy. Regarding third question, there are the increase in chances of dyslipidemia post-COVID. We are seeing it, and we are managing. If it's mild, we are managing with the primary prevention of statins. If not, if not controlled with statins, I think in future we can add on to bempedoic acid. Treatment protocol to follow for lipid profile for a dose adjustment in diabetic patients. See, for all the diabetes, suppose, as you know, the sir is there, any diabetic patient diagnosed, we consider as he has already got an MI. It is equivalent to an MI patient. So almost all the diabetic patients we put on statin therapy as a primary prevention. If not controlled by low dose of statins, then we can add a bempedoic acid to it.
Okay, doctor. I think one question was there, at what cholesterol levels? So any specific number of cholesterol?
I don't think there's any cholesterol level where you would specifically start bempedoic acid. It depends on an individual to individual. If it's a low risk patient, we usually tend to start statins, and we usually tend to add on another drug like ezetimibe, borifenofibrate, or nicotinic acid, or omega-3 fatty acid, only if the cholesterols don't come under control. So usually what we do is, if a patient has had recurrent vascular events, if he's had a stroke, if he's had a heart attack, if he's had a peripheral vascular disease, we want the LDL levels to come down further. Now with statins, if the LDL levels come down to 110, definitely we will add a bempedoic acid to bring it down below 100, keep it below 70 if possible, in patients with very high incidence of MACE. You understand? So there's no particular level where you start off with bempedoic acid. I mean, unless guidelines specify that we should add on at this level. I think it's left to the clinical, the patient, the clinician to decide on when he should add on a bempedoic acid. Obviously, you will add on bempedoic acid if patient is having recurrent vascular events on statins, or if the LDLs are not coming down with statins. So bempedoic acid, with the ease of use, probably the cost and the single once daily dosage, in patients who are LDLs are not coming under control, definitely it becomes an indication to start bempedoic acid early. So I would say start it off, don't wait if the cholesterols are not coming down for a few more months, trying to increase the dose to 80 mg. 80 mg very difficult for most of our Indian patients. They tend to get severe myalgias, and instead of titrating and trying to see if they tolerate 80 mg, you might as well add bempedoic acid in these.
Sure, doctor. I think there are no questions left. So it was indeed a pleasure and honor having you, doctor, during this webinar. We, on the behalf of Hetero Healthcare, would like to extend our sincere thanks for your comprehensive session, and we are sure our delegates would have got the enlightened regarding the molecule, as we have conducted all the possible aspect of the session. Also, I would like to extend our thanks to all the delegates for the warm presence. Thank you all for joining, doctor.
Thank you. Thank you, Siddhan.
Thank you. Goodbye. Bye, sir.
Thank you, Siddhan. Thank you.